A 63-year-old with a renal tumor underwent a percutaneous radiofrequency ablation. He represented 3 weeks after the procedure with abdominal pain. I am showing you pre-procedure and procedural CT scans. Describe the findings.
All right, let's take a look. The pre-procedure CT demonstrates a well-circumscribed, predominantly exophytic renal tumor at the anterior aspect of the left kidney. The second image shows the radiofrequency ablation needle positioned correctly in situ directly within the center of the renal mass. The ablation zone appears to cover the mass with a satisfactory margin.
I am showing you the follow-up CT scans obtained at representation. Describe them, state the diagnosis, and discuss the complication mechanism.
The follow-up CT scans demonstrate successful ablation of the anterior left renal mass with no residual enhancing tumor. However, there is new onset hydronephrosis of the left kidney, accompanied by dilatation of the proximal left ureter. A focal post-ablation ureteric stricture is identified in the mid to lower segment of the left ureter, corresponding to the zone of thermal injury. The diagnosis is a post-RFA ureteric stricture causing left-sided hydronephrosis. Pathophysiologically, the proximity of the ureter to the ablation zone led to unintended thermal injury, resulting in ischemia, necrosis, and subsequent fibrotic scarring.
What other complications can arise following percutaneous renal tumor ablation?
Complications are generally rare, but can be classified into thermal, mechanical, and infectious etiologies. Thermal complications include PUJ strictures, urothelial injury leading to urine leak or urinoma, and adjacent bowel wall necrosis. Mechanical complications include perirenal hematoma, active arterial hemorrhage, pneumothorax, or splenic laceration. Tumor seeding along the active biopsy or ablation needle tract represents a rare late complication.
How do the clinical success and complication rates of percutaneous ablation compare to surgical resection?
Studies demonstrate that for small renal masses under 3 centimeters, percutaneous ablation achieves equivalent long-term oncological control compared to partial nephrectomy. Ablation offers the distinct advantage of preserving more normal renal parenchyma, resulting in lower rates of chronic kidney disease. Furthermore, ablation is associated with significantly lower overall perioperative morbidity, shorter hospital stay, and faster recovery. However, the risk of local tumor recurrence is slightly higher, necessitating close radiological follow-up.
Explain the standard radiological follow-up protocol and how you would manage this patient as a radiologist.
The standard follow-up protocol after renal ablation includes contrast-enhanced CT or MRI scans at 1, 6, 12 months, and then annually for 5 years. As a radiologist, I would recommend immediate decompression of the left collecting system to preserve renal function. This is best achieved via retrograde ureteric stenting or percutaneous nephrostomy insertion. I would refer the patient urgently to the urology team for definitive management of the stricture, which may require balloon dilatation or surgical reconstruction.